Greetings, this is Dr. Reuben Mutagaywa. I'm a cardiologist and I'd like to take you today on the session on hypertension in special populations, and I will particularly focus on two important conditions, that is elderly group and hypertension in the diabetic patient. So at the end of this session, you should be able to understand the need for guidance of hypertension management in special population, and also you should be able to understand the principles of management of hypertension in special populations according to guidelines, and in this respect is on diabetes and in the elderly population. But also you should be able to appreciate and organize the referral of these individuals to specialist clinic or specialist hospitals for hypertension when the need arise. So our outline is as I'll give a brief of introduction on the subject, and also I'll dwell on hypertension in the elderly. Later on, at the end, I'll dwell on hypertension in diabetes, and I'll finish with conclusions. As we might know, that hypertension is among the leading cause of cardiovascular mortality and morbidity, taking into account all cause of death or morbidity and mortality among the non-communicable diseases. Hypertension is the leading, and it too alters substantially the clinical course of other health conditions, and including health-related quality of life. So, health workers should always be aware of the current guidance on hypertension care in special groups and vulnerable populations, because by doing so, we can be able to prevent the complications arising from hypertension, and also to diagnose earlier on these patients and offer appropriate management. So I'll start with the elderly population, and polypharmacy and tight blood pressure control is also a challenge, because it increases the risk of falls, but also of confusion, delirium, and orthostatic hypotension, because these patients have loss of this baroreceptor functioning, and therefore they are at risk of orthostatic hypertension. And pseudohypertension is also common. That is a major discrepancy between the intra-arterial and a cuff pressure. So also measuring blood pressure in the elderly needs a bit of careful, because you might label somebody that has hypertension while he don't have, or vice versa. But also blood pressure variability and postural hypotension is very common. That is the normal variability of blood pressure, the physiological one, which, for example, at night you have the normal nocturnal dipping. In hypertension might not be apparent, and they have a postural hypertension. All this impose a great challenge when it comes to diagnosis and management. And blood pressure must be measured both in standing position and in sitting position, and the use so that you can be able to treat accordingly. Masked hypertension is also a problem, and as I said before, the absence of nocturnal dipping is common. That's why sometimes the risk of stroke in elderly is common because of this loss of normal or nocturnal dipping. And masked hypertension, it's when they go into the hospital or at the clinic, you might find that their blood pressure are normal, but when they are in other places or at home, the blood pressure is high. So in this population, one might need to really use ambulatory blood pressure monitoring to check whether they have this phenomenon. We should watch also the diastolic blood pressure during treatment, especially in those with wide pulse pressure. And we should make sure that we do not lower this diastolic blood pressure below 70 millimeter of mercury in such individuals. As we say that the main problem in this population is a systolic one. So when you are giving medication, you should always try to achieve diastolic blood pressure in the at least in the normal numbers and not below 70 millimeter of mercury, because lowering further diastolic blood pressure has been shown to be associated with increased adverse events associated with hypertension. Hypertension in the elderly need really a general geriatric assessment, and by geriatric assessment is really you need to ask several questions pertaining to other organs because these elderly patients are at risk of getting other conditions which might really impair or interfere with your management. As I said, there are some issues with sleep patterns, there are some issues with prostate issues in male, and some appetite issues. They might not be eating normally, so the nutritional status should also be assessed. And in a normal individual with 65 to 80 years old, systolic blood pressure goal or systolic blood pressure target should be around less than 140 millimeter of mercury. And in individuals who are more than 80 years, the blood pressure should be at least less than 150 millimeter of mercury. And this is some guidelines like the American College of Cardiology, American Heart Association guidelines do recommend a target of 130 over 8 millimeter of mercury. But we should always individualize, and especially in patient who has orthostatic hypotension, then or who is frail or has a lot of comorbidities, then we should always be targeting a systolic blood pressure of not less than 130, because the risk of orthostatic hypotension will further increase. So we should not reduce blood pressure further, systolic blood pressure further to less than 130 millimeter of mercury in frail individuals who has a lot of comorbidities or who has orthostatic hypotension, that is falling blood pressure when somebody stands. Higher systolic blood pressure goals in individuals with orthostatic hypotension is recommended. As I said, you should not go beyond 130, and therefore aim at 145 to 160 millimeter of mercury. But also lifestyle changes, including eating habits, little of exercises, controlling stress, but also the use of calcium channel blockers like amlodipine and other non-hydropyridines, or thyroid diuretics like hydrothiazide are preferred medication if there is no compelling indications for other drug classes. And for compelling indications is the medications which should be given to individuals who are certain disease or certain conditions. For example, in a patient with myocardial infarction, in a patient with diabetes, in a patient with heart failure. Those are compelling indications, so you should give specific medication to them. But also, AC inhibitors can also be used if tolerated, and we should always avoid beta blockers except when indicated, like for a compelling indication, like in atrial fibrillation, because side effects of these medications include confusion, bradycardia, and hypoglycemia. And as you might expect, these bradycardic events or hypoglycemic events are common even in individuals who are not hypertensive, especially the elderly. So to further not cause these side effects, we should avoid beta blockers as much as possible. And what does the society membership tell us when it comes to management of hypertension in the elderly? So they have divided these patients in several groups. There are those with preserved function. There are those with loss of function, for example, loss of decline function without significant loss of autonomy for activity of daily living. But there are those who has loss of function and they have altered activity of daily living. These have significant loss of function and they cannot do a lot. So when you want to manage these patients, you should tailor on into different groups. Starting with preserved function, the approach for treatment of this individual is rather similar to those with a younger adult with a treatment goal of around systolic blood pressure of 120 to 140. Here we are not very strict, and we should always start with monotherapy and you titrate it slowly with response, and you go cautiously. But always, as I highlighted before, the issue is orthostatic hypotension in this population is common and therefore should be given special precaution. But also we should optimize treatment to prevent global cardiovascular disease or cardiovascular event. In group 2, where you have now loss of function, but you have preserved activity of daily living, then you should always assess this function assessment in order to tailor antihypertensive treatment and also prevent cardiovascular risk or measuring against the benefit. So you have also like the moderately altered function where you should follow like the preserved function, but also if you have significantly altered function, then the target here should be like for those with loss of function and altered activity of daily living. Now, for patient with problem with activity of daily living, here you should do a reconciliation and revision of the antihypertensive therapy. Really, if antihypertensive treatment is considered, then start with one drug at low doses, and you should go slow, targeting systolic blood pressure of around 150 millimeter of mercury, avoiding using more than 3 antihypertensive medications. And if systolic blood pressure is less than 130 millimeter of mercury, or if you have evidence of orthostatic hypotension when under treatment, then you should consider using antihypertensive treatment, especially when you are in combining drugs. But also you should identify and correct other factors or other medications, other conditions which should be decreasing blood pressure in this population, because you might cause harm when reducing blood pressure very significantly, especially causing blood hypoperfusion to the brain. So with that, I have now come to end to this part one of the presentation, and I will go on with the next group, and this is hypertension in patients with diabetes. Prevalence of hypertension among patients with diabetes is high. It is reported to up to 47% to 60%. And as you might know, this we say it's like twin conditions, hypertension and diabetes. They mainly coexist because they share the common pathogens or pathogenetic risk factors. And they both act synergistically to cause organ damage. And they also they are at risk of increased macro and microvascular complications. For macrovascular complications, we talk of conditions like heart attack, stroke, kidney disease, but for micro complications include like neuropathy and nephropathy, also retinopathy. These are common microvascular complications. And the pathogenesis of hypertension in diabetes is complex, but include the relations of sympathetic overactivity, but activation of the renin, angiotensin, aldosterone system in the kidney, but also the abnormal sodium handling has been implicated, a dysfunction of the endothelial system, but also there is impaired insulin mediated vasodilation, there is increased inflammatory conditions, and they have abnormal immune response. All these have been implicated in hypertension in diabetic population. And the United Kingdom's PDS study has shown that reducing blood pressure from 160 over 94 millimeter of mercury to 144 over 82 millimeter of mercury has shown to be reducing mortality in this population, and heart failure mortality also, as well as macrovascular complications. So the benefit of blood pressure control has also been seen in other studies which have involved diabetes and hypertension population, like the whole heart study, the Hascott study, HOT study, and the SHAPE trials, which used calcium channel blockers. But also, the threshold for treatment in this group is a bit on the lower side, and it is around 140 to 90. That is when you should treat. If somebody is a diabetic, you should not wait for blood pressure to be more than 140 over 90 and you start treat. Exactly 140 over 90, you should start to treat. And we know that because early treatment or blood pressure control in diabetic population do prevent or reduce the risk of microalbuminuria, which is if it goes on, it can lead to a nephropathy or overt renal disease. But also, you reduce the risk of new or worsening nephropathy, but also the risk of diabetic kidney disease and cardiovascular risk. Masked hypertension and resistant hypertension in diabetes population is common. I have already defined what is masked hypertension, but here is again resistant hypertension. This is when somebody is using more than 3 antihypertensive, one of them being a diuretic, but the blood pressure remained uncontrolled. This is very, very common in a diabetic population. And in these circumstances, ambulatory blood pressure monitoring and home blood pressure monitoring has been advised or have been shown to be important by from the International Center of Hypertension guideline, and should be really used when you suspect this masked and resistant hypertension. But a tighter control in those with proteinuria, in those with kidney disease, those with high cardiovascular risk factors. For example, if they have more than 3 factors, they are elderly, they have kidney disease, they have target organ damage, then you should aim at tighter blood pressure control. And the recommended target in diabetic population for blood pressure is less than 130 over 80 millimeter of mercury. What are the drugs used in diabetic population? The first drug of choice is ACE inhibitors or ARB, especially in those with albuminuria, because these medications, the ACE inhibitors and ARB, they have shown to reduce the risk or the problem of proteinuria. They have anti-proteinuric effect, and when you have albumin to creatine ratio of more than 130 milligram per gram creatine, then you should consider these medications. But also, calcium channel blockers and diuretics can also be used as add-on therapy to ACE inhibitors or ARB. But we now have these new anti-diabetic medications which have shown to have hypertensive benefits, like the SGLT2 inhibitors, the GLP-1 antagonist, receptor antagonist, but also the DPP-4 inhibitors. These are new molecules in the market which have shown to have great benefit in hypertensive patients who are diabetic. They are primarily diabetic medications, but they have hypertensive benefit. Sorry. We should also monitor orthostatic hypotension, because these patients, they have already autonomic dysfunction as the common microvascular complications of diabetes, and we should check their blood pressure when they are in sitting and in standing position. But also, importantly, we should monitor for metabolic effects of the antihypertensives in diabetic, because we know some of antihypertensive medications, they can cause side effects which might be of metabolic problem. Now, the metabolic effects of antihypertensive in diabetic patients are like the following. When you are using thiazides, these thiazides, they have problem with raising blood pressure, blood glucose. So one might need to increase the dose of oral antihypoglycemic medications, or if you're in injectables, when you're using a thiazide, or low dose of thiazide might be used. But also they do raise the lipids, like the low density protein, which is a bad cholesterol, but also they lower high density protein, which is good cholesterol. So the overall problem is thiazide diuretics is to raise bad cholesterol and to raise blood sugar. Beta blockers also, they have problem with raising blood glucose, but also they have problem with raising triglycerides. And the main problem also include decreasing awareness of hypoglycemia. And this has been shown to be problematic because when somebody is not aware of hypoglycemic the hypoglycemia symptoms like the sweating or the palpitations, lethargy, the common symptoms and signs of hypoglycemia may end up with serious complications of hypoglycemia, which include brain damage. So one should be very cautious when using these beta blockers in diabetic population. The use of calcium channel blockers is neutral on the glucose effect, but also on the lipid and but the dihydropyridines like amlodipine and nifedipine, they have shown to have to increase proteinuria. So this is also a concern in when you're giving this medication. The ACE inhibitors, they are neutral in glucose metabolism and lipid metabolism, but they have very specific to have a renal protective effect. That's why we recommend them for patients who are particularly at risk of renal failure or CKD. Alpha blockers, they have effects on raising HDL, which is really good thing, and lowering LDL, and they have neutral effect on glucose metabolism. So, in conclusion, hypertension in special population requires individualized approach and attention to details. When talking of elderly, you can see the issue of polypharmacy, but when you're talking of diabetes, you can see issues related to metabolism or complications or the target blood pressure. And one should always refer patient with this category to hypertension specialists or centers as early as possible with aim to try to prevent complications and to offer appropriate treatment. So with that aspect, I would like to say thank you for your attention and wish you good revision of our lectures and to have your own reading, because as you know, we have several online materials including the one we post, but also interactive sessions. And I would like to welcome everyone for questions and or concerns. Thank you once more.